Thank you very much. Thank you all for this invitation to talk today about a little bit about epidemiology and long-term evolution of long COVID. So it's a huge program, and I think a lot of you know already a lot of things. And the idea of this presentation is more to talk about the tools that we have to see what we can do and how epidemiology may help in the future for long COVID. So first of all, well, I have a declaration of interest. I received some grant from national and some foundation, and I also work with the companies. So when there's one statement that I think everybody agree with that there's a low number of very good quality survey on epidemiology on long COVID. And this is due to, as it has been said just before, to the numerous definitions. The fact that it was this new disease appeared during a crisis, it was difficult to organize everything, and nothing was really designed to do a specific follow-up of this condition. But we have multiple tools, cohorts that already exist, and we change these cohorts to work on this new condition. New cohorts saying that it's a new disease, let's start to follow the patient, and hopefully having control to see if there are differences between both. Let's do transversal studies to see if there are more cases or less cases. And of course, medical database that already exist, and there's a lot of examples, especially in the north of Europe and in the US, where there's a lot of data from the general practitioner, and some very amazing study has been done on this kind of database. So as it has been said just before, it's exactly the same slide, but shown a little bit differently. You have a lot of definition. On the left, you have it's a literature review that highlights the different definition that has been used in the literature. And on the right, you have the paper from the New England who shows the difference between the main national or international definition. And so, in epidemiology, we need to define a case, and if two studies hasn't the same definition of a case, it's very difficult to compare between countries and even inside one country. So, which one is the good one? To me, there is no answer to this question. I mean, it really depends on what we want to do with this definition, which are more, to me, classification than definition. If we want a broad spectrum to see what are the consequences of an infection due by COVID-19, we need to have the wider spectrum. But if we want if we are in front of a patient to give him the more precise diagnosis for a treatment, maybe we need other definitions. So it really depends on what we want to do, and the definition it may change depending on the objective of the definition also. So up to 2022, there were various other definitions also, and up to now, even in this definition, if we say that we use the WHO definition, you have a wide number of symptoms. Some study will use this symptom and other will not. And because it's hard to be completely inclusive in terms of symptoms, there are a lot of literature about the 100 symptoms that long COVID may have, and it's difficult to do some survey with so many questions. We need also, for a methodological approach, if we want to have a follow-up, which is very important to see what is the natural evolution of this disease, we need to have the same information asked at each time points. And of course, we are frustrated that we discover that there's a new condition that is associated to COVID-19, and it's not in the new publication. But to be methodologically correct, sometimes we don't need to move to move. Exactly. So. So now, how was used the epidemiology in long COVID? The first one is confirming that long COVID exists. It was the first aims of epidemiological survey, and the first one was done by the US. The first one which used a comparative group, because to say that it exists, it needs to be compared to see if something is different between someone who has COVID and someone who has not COVID-19, who has a history of COVID-19. And this survey already show it was done at the beginning of 2021, and sorry, I'm turning the head, and I think you don't hear me then. Sorry. It showed that a lot of different symptoms that everybody here knows that were more prevalent in people who had a history of COVID-19 when compared to others who has no history of COVID-19. But as you see here, the definition is more than 4 weeks after the onset. So it's another definition, which was very frequent at the beginning of the crisis. It's persistent symptoms. It was after 4 weeks. In France, we had another methodology. We use existing cohorts. We have existing cohorts in the general population, which were made to follow chronic conditions. And at the beginning of the crisis, we asked them to work together and to ask questions about the crisis. At the beginning, it was not designed for long COVID. And when we hear about this new condition, we add some questionnaire within the follow-up of this survey, and we have several questionnaire about symptoms. And we did a first paper in which we have serological, I will not do the detail, but we had serological results from the first waves. And we have also the fact that there were symptoms at the acute phase. And we had patient participants with symptoms during the pandemic without positive serologic, and some people with positive symptoms, with symptoms which could be related to COVID-19, acute COVID-19, and no serology and negative serology. So the idea was to compare these two groups. Also, we compared the other group, of course, because we were wondering if there was something which was specific to this crisis. And we consider, it's a strong assumption, but we consider that seronegative might have symptoms due to other virus or other conditions which are similar to COVID-19, but are not COVID-19. And when we compare these two groups, there are still differences. There are still differences in a lot of symptoms, and maybe more if we had more power. For example, for some cognitive disorder, we reached significance, but the number of patients was low. So it means that if we compare individual with ascertained COVID-19 with acute symptoms compared to individual without this without this certainty, but with symptoms that are similar to acute COVID-19, there is difference. So it means that it gives more symptoms than other conditions which are similar at the acute phase. Okay, so now we know that COVID-19 exists. I hope everybody here agree with that. No, I think in this room it's sure. So the next step is estimating the prevalence of long COVID and to estimate the risk factors. And so I will show different results, but I will start with a French survey which has been done by our NIH, which is Santé Publique France. We did 2 samples within the general population. The first one at the beginning of 2022, and we show that 4% of the overall adult population had persistent symptom or long COVID. And there were some factors related to this condition. And what is interesting is the graphic on the left, which highlights that depending on the time of infection, of course, the number of long COVID decrease, but stay high. So 6 months later, we did a second survey with a more robust methodology with more patients, and we still find 4% of long COVID using the WHO definition. And what is interesting in this value, that it seems to be the same value as before, but the patients are not the same. We still have half of them who belong to the first waves of the crisis, of the epidemic, and the other, there's a turnover. So there are short long COVID, if I can say, and long COVID. This longitudinal, it's not, we can't consider that it's a longitudinal analysis because the methodology was not exactly the same, but we can say that the value, the number of cases remains stable, but it was not exactly the same patient. What is interesting also is the table that we have at the end of the slide. It shows that depending on the waves and the variants, you have a prevalence which remains high for Wuhan, the first wave of Wuhan, and was quite quite high for Omicron, but the survey was done just after an epidemic in France, and so this value may decrease within time, because we know now that Omicron give long COVID, of course, but to a lesser extent. And what is the originality of this survey is that we ask a lot of different questions, and these questions were made to try all the definition that we had at this time. So our main analysis was done on WHO definition, but we try also NIH definition and other definition. And you see that from, depending on the definition we use, we had from 2.5% of the population to 12% of the population. And the highest value was found if we ask the question, do you consider you have long COVID? And you see that this is different depending on age on this figure. Here is a recent systematic review on the prevalence of long COVID. And what is interesting is the conclusion of the paper, which is on the left. It said that prevalence from study using routine healthcare record, there are discrepancies, among studies. If we use data from routine healthcare record, we have 13.6% of individuals with long COVID. If we have self-report survey, it can rise to 44% and even 87% in some survey. If we look at all the pathology that may be associated to COVID-19, we can rise this prevalence. And if we look at study that take into account hospitalized patient, of course, the prevalence is higher. So it's very difficult to give a simple number in this situation, but however, it's always high. So now risk factor. So there's a lot of paper which are reference. I show you some reference from the beginning of the study to up to now, and we can say that confirmed risk factor are, of course, hospitalization, severity, intensity of the acute phase, and it's important to differentiate, because when you talk to physician, what is a severe COVID-19, they only think, usually when they don't know long COVID, they only think about respiratory problems, but it can also be the number of symptoms that has been declared the acute phase. So I prefer to use the intensity of the disease at the acute phase. Age, female sex, no history of vaccination, and I show you on the right some result from a meta-analysis on the impact of vaccination on long COVID, and also the result of an amazing work on the veteran cohort in the US, showing that the impact of the waves and of the vaccination status, saying that it's important to be vaccinated against SARS-CoV-2, not to have COVID-19 and long COVID, vaccination, tabagism, and also variants and waves. So now we have some risk factors, but they are very common, and most of them, with the exception of vaccination, are not. We can change age, we can change the sex, and so it's difficult. It's risk factor, but most of them cannot be changed. So the step 3 is to evaluate how is going long COVID over time. And so there are also ways to evaluate. And it's very important to know where the people are from, what is the source population, saying that if the population is taken within the general population, the evolution will be more favorable than if we look at, if we follow people who receive follow-up in a dedicated clinics. So it needs to be very, when we read this kind of paper, it's very important to see where are the patients from or the participants from. Otherwise, you can do some misinterpretation. So the first one is what we did from the general population, from the whole follow-up that we had in this survey. And I show you on the left, we have the risk factor of symptoms resolution. So if you have a high value, it means that your symptom will disappear. And if you have a low value, it means that the symptom will stay longer. And you have similar risk factor that has been found for having long COVID. They are very similar: age, sex, comorbidities such as cancer, and overweight, and also the intensity of the acute phase, the number of symptoms that were declared the acute phase. And looking at the evolution of the symptoms, you have on the right a table showing that which are the symptoms that disappear at 1 year, and you see that most of them disappear 1 year after the infection, but the one that take more time, the more time to disappear, are neurological complaints. Another work, European work from Germany, using a digital health research, a digital health software, show the resolution depending of the variants and depending of vaccination. And it showed that if you are vaccinated and well vaccinated, if you have long COVID, you may you may improve earlier than if you haven't been vaccinated. And you also find the same risk factor that we found in our study. You can also do some longitudinal analysis from long COVID cohort, people who declare being long COVID, and there's a very good work done by a French team which is called COMPARE, which follow chronic conditions, and it was asked to people who declare them as having long COVID to have an to receive follow-up using internet questionnaire, and they, depending on the intensity of the symptoms, they were able to decipher different kind of long COVID profile, and this profile may have a different evolution. So this means that depending on the symptom, their intensity, and the type of symptoms, you may have different evolution. And this is of true importance for therapeutic protocol, to see where patients are, to see how we can expect a favorable outcome. So defining then step 4 is, can we define long COVID? We are back to the first slides. Can we define long COVID using epidemiological data? First, sorry, I think it's a good. No, it's twice the same. Sorry, I can't go back. See, sorry. Okay, so. Some researchers try to do some kind of clustering using medical health data and to see if we can have some different clinical profile of individual. And you see that it's just an example. There are hundreds of, not hundred, but there are a lot of articles who try to do some kind of this kind of clustering, and you see that you have some patients that are more have pulmonary disease, others have more asthenia and neurological syndrome, but you have a strong overlap between these cluster, and it's quite difficult it's interesting in an epidemiological point of view, saying that we have different profile, but it's not enough to in a clinical practice to say, okay, so this patient is in this case, so maybe he will have this evolution. It's not enough. On the left, there's another work very similar, and in this kind of clustering, it seems that the number of symptoms is also very important, and the cluster has sometimes bias due to the number of symptoms, and so more or less you always have one group with a lot of symptoms, and it's difficult. What do we do with this paper who has a lot of symptoms? Maybe there are different kind of pathophysiological path that may explain all these symptoms at the same time. So maybe there's a need of other association with other things, such as biomarker, imaging, intensity of symptoms, and so on. We did a little work which has not been yet published, using another methodology, always on the same cohorts. The idea is to see how the symptoms interact. And you see on the upper left, the individual who are sure to have an infection due to SARS-CoV-2, and you have the little bullet are symptoms, and you see how the intensity of the symptoms, how they are connected. And it's very interesting in terms of therapeutic, because if they are connected, we can make the assumption that if we have an impact on one of the symptoms, it may change also the other symptoms. Intuitively, it's very easy to understand if you are tired. Of course, you have cognitive disorder, but the question is, if you are no longer tired, do you still have cognitive disorder? So it may help. So it's this kind of tool may use to divide and to divide the patient to trying to define some different pathophysiological process and maybe patient selection for clinical trials. So now surveillance. So for surveillance, I didn't put any results because there are many problems for the surveillance now. If we still have new long COVID in the clinics, but people doesn't test anymore, or not as much as they used to, and so it's very difficult to attribute what's their complaint to the disease, and so it's very difficult to make epidemiological data if we don't have epidemiological study, if we can't make a diagnosis. Concerning old COVID, I say old COVID from the first waves of the epidemic, it's also difficult to do a follow-up because during life we have a lot of other events, and if there's a new symptoms, if there's something new that's happened, is it attributed to long COVID or is it attributed to something else? Because aging, because of other conditions that may rise when we get old. And again, definition, as we said at the beginning, it's hard to reuse data if the definition change. If we change the definition, how can we compare the evolution? So classification are mainly done by the patient also, but it's very important to have the feedback of the patient. But there's a lack of data with ascertained diagnosis made by a physician, and as we saw before, it might be very different. The prevalence may be very different depending on who is completing the questionnaire. So in conclusion, I don't know if, I think I'm okay with time. Epidemiological data have robustly confirmed that long COVID is a reality. That's the first step. The data suggest that even during the Omicron waves, this issue persists. The modifiable factors for now is vaccination coverage to date. Epidemiology can help differentiate group for research and clinical trial purpose in the absence of other markers. And monitoring this disease will require significant implementation and money, of course. So thank you very much. And if there's one or two questions.